Hi, my name is Dr. Sarah Sammons. I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston, Massachusetts. We're here today showing this poster, which is an updated efficacy analysis of Relay 2608 plus fulvestrant in patients with hormone receptor positive, HER2 negative, metastatic breast cancer, and a PIK3CA mutation post CDK4/6. So Relay 2608 is a pan-mutant PIK3CA inhibitor. And this is the updated analysis from the ReDiscover trial, which was the phase 1 into expansion trial. Patients included in this updated efficacy analysis had to have hormone receptor positive, HER2 negative breast cancer. They had to have a PIK3CA mutation, either in the kinase or non-kinase domain, really any PIK3CA mutation. They could not have a prior PIK3CA, AKT, or mTOR inhibitor. They had to have at least one line of prior CDK4/6 inhibitor, and they could have one prior line of chemotherapy. In this analysis for patient demographics, we're mostly going to be focusing on patients that were treated at the recommended phase 2 dose, which was 600 milligrams BID. 64 patients were included. You can see about half of them had kinase and about half of them had non-kinase domain mutations. About 65% had measurable disease. About 56% had one line of prior therapy in the metastatic setting, so mostly a second line population. 100% of them had prior CDK4/6. 51% actually had prior fulvestrant or novel SERD. And 28% had prior chemo or ADC. So this is a more heavily pretreated population. About 28% had concurrent ESR1 mutations. We do see very rapid clearance by cycle 2, day 1 of PIK3CA ctDNA showing excellent target inhibition. You can see almost all patients had a reduction in their PIK3CA ctDNA, and almost 100%, not almost, but almost a lot of patients had 100% clearance. Many patients in this setting have concurrent ESR1 mutations, and you can see also clearance of the ESR1 mutation here. I think one of the most important items of consideration for this class of drugs is the side effect profile, which has been really challenging for our patients to tolerate with other inhibitors that are currently FDA approved in this class. Here is the side effect profile. You can see that 51% of patients still had some low-grade hyperglycemia. 31% was grade 1, requiring no intervention. The other 20% was grade 2, requiring really just metformin. Almost no patients, very few patients required a second anti-hyperglycemic. Only 3% had grade 3 or 4 hyperglycemia, grade 3 hyperglycemia. We're seeing some low-grade nausea, fatigue, creatinine increase, some low-grade diarrhea, which was pretty manageable. One nice thing is that we're seeing very little rash and very little stomatitis, which is pretty bothersome to patients. In the 31 patients that had measurable disease, we saw an overall post-CDK4/6 response rate of 39%. We saw tumor reduction in 81% of patients. We saw in the kinase domain patients a 67% overall response rate post-CDK4/6. You can see here that we saw responses in patients with kinase and non-kinase mutations, also saw responses in prior fulvestrant treated patients, also saw responses in ESR1 concurrently mutated patients. We saw a median PFS around 10 months in the 52 patients who did not have concurrent AKT or PTEN alterations. We know that mutant-specific inhibitors simply do not work well in patients that have concurrent PTEN or AKT alterations, which is only about 10% of patients. In the second-line patients, we saw a median PFS around 11 months. In the 29 patients that had kinase domain mutations, we saw a median PFS of 18.4 months, which post-CDK is quite impressive. We see a clinical benefit rate of 67%, which is also respectable. This compound with fulvestrant is moving into phase 3. You can see the design right here. The phase 3 trial design is going to be in PIK3CA-mutant hormone receptor positive HER2 negative breast cancer post CDK4/6. Patients can have measurable or evaluable disease. They must have a PIK3CA mutation. They must have progression on a CDK4/6 inhibitor, no prior PIK3CA, AKT, or mTOR inhibitor. Limited to patients with a hemoglobin A1C of less than 7. We do not allow concurrent PTEN or AKT mutant patients. Patients are being randomized to either ReLay-2608 plus fulvestrant or capivasertib plus fulvestrant. So we are going head-to-head against capivasertib. We're stratifying for kinase or non-kinase domain mutations, visceral disease, and geographic region. The primary endpoint is dual PFS in the kinase domain mutation altered, and also in the overall population. So to conclude, ReLay-2608 plus fulvestrant is a new mutant-specific PIK3CA inhibitor. It has a favorable toxicity profile compared to other competitors that are already FDA approved. We need better tolerable drugs for our patients. We think it has very preliminary, exciting activity, and it's moving into the phase 3 setting.